Thank you for your kind introduction, and good morning, everyone. I'd like to thank APEC for inviting me to this wonderful event in tribute of Prof Redman. He was so inspiring to work for when I was a junior doctor at the JR in Oxford, and that's sparked my interest in preeclampsia research. So today I'm going to talk about hypertensive disorders of pregnancy and future cardiovascular health. So this is really just a slide to go over a woman's life course, and it demonstrates how throughout the woman's life, starting as a teenager, they could have obesity, hypertension, dyslipidemia, and throughout the lifetime, once they get to pregnancy, this could manifest in preeclampsia and other adverse pregnancy outcomes such as preterm birth, SGA, miscarriage, GDM. And when she gets to later in life, this could result in her having cardiovascular disease, coronary heart disease, and stroke. The underlying mechanism is not quite known at the moment, so I've just listed a few possible options here. And of course, there's been a lot of recent changes in the management of hypertensive disorders of pregnancy, starting from screening, prophylaxis, diagnosis, medication, delivery, and postnatally, and that's where I'm going to be focusing most of my talk on. But just going back a little bit from post-delivery, so this is a study that I did looking at a cohort of women with preeclampsia and using a US data set between 2004 to 2015 and looking at what happened to them at the time of delivery. So we split the HDP cohort into subgroups with including chronic hypertension, gestational hypertension, preeclampsia, and superimposed preeclampsia. So with the outcomes of mortality, we showed that having preeclampsia and superimposed preeclampsia gave you the highest risks, whereas gestational hypertension didn't really increase your risk of mortality. Looking at myocardial infarction, again, having gestational hypertension didn't increase your risk, but having superimposed preeclampsia increased the risk of MI the most. With peripartum cardiomyopathy, this outcome, again, it's the superimposed preeclampsia group gave you the highest risk. And lastly, with arrhythmia, it's the other way around. So it's having chronic hypertension that gave you the highest risk of having arrhythmia at the time of delivery. We also, skipped. We also looked at preeclampsia and future cardiovascular health, and we did a systematic review and meta-analysis looking at papers from the last decade. So this showed that having preeclampsia increases your risk of heart failure, stroke, coronary heart disease, and cardiovascular disease death between 2 to 4-fold. And is having the heart failure, having preeclampsia increases your risk of heart failure by 4-fold, whereas for the other outcomes is roughly 2-fold for stroke, coronary heart disease, and cardiovascular death. In the sensitivity analysis, we looked at the length of follow-up and showed that starting from delivery, even within a year, the risk is increased. The risk is highest between 1 to 10 years after delivery, but this persists over 10 years. And of course, the risk is highest between 1 to 10 years is because this is relative to the baseline risk. And so over 10 years' time, everyone else's baseline risk increases as well. In terms of the sensitivity analysis, looking at confounding factors, so basically we looked at studies that adjusted for either age, BMI, diabetes, smoking, or hypertension. This showed that the risk for adverse cardiovascular outcomes persists, but it is the heart failure that outcome that's got the highest risks here. We also looked at the association between preeclampsia and diabetes in a systematic review. And this showed that if you group the diabetes type 1 and type 2 together, then the risk is about twofold. So having preeclampsia increases your risk of having diabetes by twofold. But then when you split it between type 1 and type 2, the risk is mainly driven by type 2 diabetes, here 2.37-fold, which makes sense. And with the sensitivity analysis, again, we looked at the length of follow-up, and this time we split into less than 1 year, 1 to 5 years, 6 to 10 years, and over 10 years. And the highest risk seems to occur around 1 to 5 years, around threefold. When we did our sensitivity analysis, excluding baseline comorbidity, either excluding baseline diabetes or baseline hypertension, the risk was still there. Oh, don't know what happened there, okay. For the confounding factors, we adjusted for BMI, age, and gestational diabetes. And again, the risk persisted for increased risk of diabetes following preeclampsia. So mechanistically, it is very difficult to know why there is this association between having hypertensive disorders of pregnancy and cardiovascular disease in the future. And here are some possible mechanisms. So it could be cardiac adaptations to adverse pregnancy outcomes. It could be pre-existing cardiovascular risk factors. I think this is probably more likely to be the cause, or in combination with other mechanistic causes, such as shared genetic risk between adverse pregnancy outcomes and cardiovascular disease. Could be an element of maternal inflammation as well, or placental ischemia or vascular dysfunction. And all these in combination leads to cardiovascular consequences such as left ventricular hypertrophy, decreased arterial compliance, endothelial dysfunction, and coronary artery calcium increase and stroke. So what next? Well, we also did a survey of healthcare professionals. We surveyed about 500 healthcare professionals, cardiologists, obstetricians, both in the US and in the UK, through social media, what was used to be called Twitter, now X, and asked them 4 questions. So we asked them about, during cardiac risk assessment, well, what do they inquire about? So this was a survey about all the different adverse pregnancy outcomes. So, so that's why there's quite a few over here. And thankfully, most of them do inquire about having gestational diabetes, whether the woman had gestational diabetes as part of their cardiac risk assessment. We also asked them whether they were aware of association of adverse pregnancy outcomes with future cardiovascular outcomes, also asked about risk scores and guidelines in this area. And again, thankfully, most healthcare professionals were aware of the risk of gestational hypertension with adverse outcomes. But in terms of the risk factors, risk scores, they weren't as sure. So only about 20% were aware. And in terms of guidelines in this area, about 40% of the healthcare professionals we surveyed were aware of relevant guidelines. So we also asked them, the next thing we asked them was, when do they think women with high-risk pregnancy should be screened for cardiovascular disease postpartum? Now, this is probably a bit of a trick question because there's no real consensus, but we just wanted to get a sense of what people thought. And so it was interesting to see such a spread of answers with some people, about 5% saying never, they should never be screened, which was not great. But most people said they didn't know. We also asked about what do they think the guidelines said? And in fact, some guidelines said about once every year, and other guidelines didn't say a lot. So this was reflected in the answers from the healthcare professionals as well. These are some of the relevant guidelines in the area, if you're interested. And thankfully, this topic is being recognized more and more by both obstetricians and cardiologists. And there are a few kind of position papers in this area stating how important it is to work together in a multidisciplinary approach for women with cardiovascular disease or women with pregnancy outcomes, and the importance for cardiologists to be aware of that. So then there's position papers about increasing the workforce in cardio-obstetrics as well. And lastly, I think we can start. This is all about cardiovascular risk assessment for the woman for later in life. So I think it is, as a starting point, this is where we should be. We should be not only thinking about traditional cardiovascular risk factors, but also assess for adverse pregnancy outcomes and identifying them as cardiovascular disease risk enhancers. So thank you for your attention. Just like to acknowledge the various funders that have helped me throughout the years. So NIHR, North Staffordshire Medical Institute, and our local UHNM charity. Thank you.
Thank you very much for that fascinating talk. And as you say, it's of increasing importance in recent times. And I think at the moment when looking at the alterations in healthcare and in looking at women's health as a continuum, it is extremely important to try and get this information out into the general health and the cardiovascular health and future life. So thank you for that.
Thank you.